present this topic to you today. I understand that there are many world experts in the field of spinal cord, so it was it was not an easy task for me to come up with a presentation that I will try to keep their interest. And I understand that we also have many junior colleagues that they're new to the field, so I felt that we need to provide some more background information that they might find useful. So we have to cover many topics, so I'll start. So I'll start with a quick clinical case. So this is a 67-year-old man with some balance issues and neck pain that goes up to 8 out of 10. And there is a small disc herniation that you can see here, and a slight spinal cord deformation on the axial cuts. But on the flexion extension MRI, you see here on the extension that the stenosis gets worse, while on the flexion, the stenosis gets better. You can see here the spinal cord, the CSF. So this is a kind of borderline case whether we should offer surgery or not. There are some factors like the spinal cord signal change here that shows that there's some kind of active inflammation going on in the spinal cord that will lean us towards surgery, but his symptoms have remained stable. So we have opted to closely monitor him. And on top of all the other things, there is a degree of I will call it instability, but hypermobility of the cervical spine. And you can see that on the lateral views, there is a degree of spondylolisthesis. And if we actually measure that, it's 1.8 millimeters. And when he's flexing the head, that degree of spondylolisthesis goes up to 3.5. So again, a very borderline case. And we have opted to monitor him after explaining, all the options, both the surgical options and non-operative options. But the real the real issue here is that we're not certain what is the best option for him. So someone might consider the previous case as kind of an esoteric, like neurosurgical dilemma that probably doesn't apply to, to a rehabilitation doctor or to, a general medical doctor. But there's this recent study that they're talking that the prevalence of asymptomatic cervical spinal cord compression can be as high as 24%. So these MRIs, like the one that we saw, might be much more common in general population, and thus the threshold for getting an MRIs and the availability of MRI becomes higher and higher. We might be seeing more of these findings. In many cases, they might be incidental. So it's important to be familiar with the topic of spinal cord compression and cervical myelopathy. And this study, they argued that the prevalence of myelopathy might be as high as 2.3% in the general population. I won't take that number as an absolute number, but it's an indication that this is a relatively common disease that I think that we should all be familiar with. And it's now regarded as the most common cause of spinal cord dysfunction. And actually, there are some people who call degenerative cervical myelopathy as spinal cord injury in slow motion, because we're dealing with spinal cord injury, but in a more like chronic way of developing. And somebody might say that the previous patient had mild symptoms, didn't really affect that much his quality of life. But is this the case with all the DCM cases? And this study a few years ago, they actually saw that for the SF36, which is a common quality of life metric, the cervical spondylotic myelopathy, and a quick note here, this condition, it can be referred as CSM or DCM. We're basically referring to the same thing. So they have a very low quality of life, both in the physical component, also the mental component. It was only the back pain that had a lower mental component, and all the chronic heart failure that had a lower physical component. So again, I won't take these numbers as absolute comparison between the pathologies, but it is an indication that myelopathy can definitely have a big impact on patients' quality of life. So let's take a step back. What is the degenerative cervical spinal disease? So this is part due to normal aging, but also their lifestyle factors. And we also know that some of the anatomical changes that happen with myelopathy, they kind of propagate and bring more degeneration to the spine. And with most spinal pathology, it can present with degenerative cervical spinal disease can present with three main symptoms: axial pain, radiculopathy, and myelopathy. We don't really know exactly what is the prevalence and what is the relationship, because there are many challenges in actually quantifying the epidemiology of these diseases. They're not always present. They might fluctuate over time. And also for myelopathy, as we will see a little bit later, it's not really clear what should be the diagnostic criteria for myelopathy. So a few things about the degenerative spine. This is, again, one of the first things that happen, we believe, is the degeneration of the disc that brings then several changes that lead to stenosis and also instability. And about myelopathy, we believe that it starts with the compression or the deformation of the spinal cord that can be either continuous, being there all the time, and we usually call that a static, or intermittent, and we call that dynamic. We saw in the previous example with that patient on flexion and extension, there was definitely a significant difference in the anterior posterior diameter of the spinal canal. So there is a dynamic component of spinal cord compression in many of these cases. Another condition that can cause myelopathy, and we used to consider as a separate entity, but now it falls within this degenerative cervical myelopathy spectrum, is the ossification of the posterior longitudinal ligament. And you see here the ossification. You can also see here the ossification. And the question that frequently comes up is how much stenosis is required in order to cause myelopathy. And I really like that study. It's not a new study, but I still think that it's probably the best evidence we have. And it showed that actually there's not like a very absolute cutoff point. But what they found is that when the anterior posterior diameter of the canal is more than 14 millimeters, none of the patients had myelopathy. When it was less than 6 millimeters, all of them had. And between 6 to 14, which is actually the usual anterior posterior diameter of the canal for many people, it depends. And there are many factors that we still don't know what will make a patient to develop myelopathy versus another one who doesn't have. And some of the factors we think that there might be the increased range of motion, like again, in the first example that we saw, that patient had hypermobility on flexion extension of the cervical spine. And when we have a patient with cervical myelopathy, or we suspect cervical myelopathy, we do the standard clinical evaluation that we take the history, we assess for any red flags for serious spinal conditions like weight loss or any recent trauma. Weight loss is for cancer, or recent trauma that might suggest traumatic etiology. We ask specifically about myelopathy symptoms, and we'll see what this might be. And then we do the standard neurological exam. And it's very, very important to do a thorough motor strength exam and also to assess the gait. We believe that the gait is especially the tandem gait examination, is a very sensitive clinical finding for degenerative cervical myelopathy. And here's a little bit more comprehensive table of the signs and symptoms of DCM. The ones that I would like to emphasize is the loss of manual dexterity. This is very common and very early in the disease. The patients usually describe that they feel that their hands are clumsy. They cannot use their phone, or they cannot use the fork and knife when they're eating as well as they did before. And gait imbalance is also very, very common and a very early sign in the course of the disease. But we need to remember that there is not like a single finding that will allow us to place the diagnosis. Usually it's a combination, and there's active research right now that we're doing to see if there's one symptom or sign that is more sensitive, more specific than the others. Here's a questionnaire that actually addresses the 4 main symptoms, or very common symptoms of myelopathy. It's more targeted for primary care physicians to allow with the early diagnosis of myelopathy. So these are, again, the 4 main symptoms that we see or we hear very frequently from patients. They describe that they're dropping things, the balance might be off, and they might feel weakness in the arms and numbness as well in the arms. And they found that if the answer is yes to 3 or more of these questions, then there's a very high sensitivity to pick up myelopathy. And there are many clinical scales for myelopathy. And, while in traumatic spinal cord injury, we all use INSCI, but that's not a very good scale for DCM, because first of all, it takes a lot of time, it requires like specific training, and is not sensitive to pick up the subtle changes that these patients have in the early phases of the disease, where it might be just some dropping of things, some numbness, the balance might be off, which although they might not sound as serious as the motor deficits of a traumatic spinal cord injury patient, but for a highly functional individual, they can have a significant effect in their daily activities and their overall functional status, as we saw with one of the studies. So also, what another challenge that the spinal cord, controls so many functions, and it's very difficult to come up with a relatively short clinical outcome, so short to evaluate clinical outcome scale that will also be comprehensive. And these authors, they suggested that we should actually track more than one clinical outcome, and like the MJOA, and we'll see what these are. So the first myelopathy clinical scale was this by Nurick. We don't really use it that often anymore, although it's a simple, but it's a simple outcome measure, but it doesn't really capture all the granularity in the disease. The most common scale is the modified JOA, where basically we assess 4 different functions. One is the motor function of the upper extremities, motor function of the lower extremities, the sensory function of the upper extremities, and we check also the bowel and the bladder. We ask about the bowel and the bladder, actually the bladder. So this is the most commonly performed evaluation, or the most commonly used clinical outcome scale. It goes from 0 to 18. Another is the pain scale that we use because it's very commonly present in DCM patients. And then this is the neck disability index, although it's not specific for myelopathy, but we also assess that as with all cervical spine diseases. And this is a quality of life outcome measure that we also use very, very frequently. So the differential diagnosis of DCM is actually quite extensive. And in cases where we have a degree of stenosis, but we are not convinced that this is the cause of the symptoms, we very commonly refer the patients to neurology, because as you can see here, this list is already pretty extensive, and it doesn't include all the different diseases that can mimic DCM. So in these cases, we just refer the patient to an expert to investigate further if we're not convinced that the compression of the spinal cord is enough to cause the symptoms. In regards to the imaging workup, we get very frequently X-rays. We saw in that previous patient, we also added the flexion extension because it can reveal dynamic instability. We also get an MRI without contrast. And in some special cases where the patient has a lot of hardware, metal hardware, and there is a lot of magnetic artifact, or if there's a contraindication for MRI, then we might get CT myelography. And also when we're planning to do surgery, we very frequently get a CT scan to see the bony anatomy in greater detail. But again, when we're evaluating the findings, we should try to correlate them with the patient's symptoms, because the stenosis is actually, it can be very, very prevalent. It doesn't mean that every patient with stenosis will also have myelopathy. And that's something we try to clarify with this publication, where in some disease, like if you have intracerebral hemorrhage, you get the CT scan, you see the hemorrhage, and then you can place the diagnosis that the patient has hemorrhage. But that doesn't apply for DCM because, again, as we said, there are patients that they might have stenosis without myelopathy. And in these cases, in DCM cases, we get the imaging to support the diagnosis that we already have the clinical suspicion that the patient has this disease, and it's also to rule out any other conditions. So it's not so much to rule in the diagnosis, but more to support and rule out any other conditions that might mimic the DCM. And there is some ongoing research. Actually, they have found that DCM can cause changes in the brain. And we know that very well from spinal cord injury, that there are changes that happen in the brain, both at the cortex, at the cortical level, but also at the brainstem level or the thalamic level, as a response to the spinal cord injury. And also, in addition to the regular MRIs, we have some new modalities that we're still investigating if they can provide us with more information for DCM. In regards to the neurophysiological workup, it is very, very helpful basically when we want to rule out other conditions like peripheral neuropathy. It's a very common clinical scenario to have a patient with gait problems and a degree of stenosis, but also have like a significant diabetes. So in these cases, we don't know if we're dealing with diabetic neuropathy versus DCM. And in these instances, the nerve conduction velocities, EMG, SSCPs can be very helpful. And also during the surgery, we always monitor these patients with motor evoked potentials and somatosensory evoked potentials to make sure that the surgical maneuvers don't cause any additional compression or any additional injury to the spinal cord. And we're still not clear about what the role of these modalities are to monitor the disease. The reason is that we don't have very specific changes in DCM that will make the neurophysiological workup more useful for monitoring the disease or to quantify the spinal cord dysfunction. But this is an area of active research, and this might change in the next years. So another thing that is commonly, we commonly see that in the literature are the physical performance tests for the diagnosis of DCM. And there's this recent study that they show that all these tests actually they perform well for detecting and monitoring the DCM, but they are not very practical to administer them in the office setting. And there might be an opportunity for further research to see if one is better than the other. So probably we can do that, or probably refer the patient to physical therapy for a more thorough evaluation of these tests. And these tests can be helpful, but there are some people who argue that this is kind of an outdated way to assess the physical performance of the patients. Now we have all the wearable technologies, like we have the watches that can monitor many physiological parameters, and they do that continuously. So probably in the near future, we might have applications through the wearable technologies that will allow us to assess a little bit better the physical performance of these patients. And also, there are some people who claim that computer vision might have an application where instead of us trying to quantify, for example, how many seconds it took for the patient to do the 9-hole peg test, then a computer vision might be able to assess if there's any tremor, if there's any inaccuracies in the patient trying to perform the test, and do that more easily and more objectively than any kind of evaluation by a human. So there are definitely opportunities for further research in that field. And there is, back in 2013, there was a study that showed that there is actually a significant delay from the initiation of symptoms to the diagnosis of myelopathy. And this has to do again with the fact that it might present with subtle findings, and initially the primary care physician might attribute these changes to normal aging, or they might not take the complaints very seriously because initially they're very subtle. And several years later, actually there was not much progress in that other study. The patients reported that there was a delay 1 to 2 years between onset of symptoms and getting the diagnosis. And to make things even worse, there was a recent study that they were basically claiming that this disease is not only there might be a delay in diagnosing the disease, but there might be a significant other diagnosis or other recognition of the disease. So one of the limitations is that we don't have very robust diagnostic criteria about what constitutes myelopathy and when we can safely place the diagnosis. So I'll show you a few things from the research that we're doing right now. So we try to review the literature and see how authors in clinical studies, they have defined myelopathy and how they were able to place the diagnosis. And, we consider that can be like a proxy for coming up with some objective diagnostic criteria. And we did a literature search, but we came up with like 1,600 different studies. So it was basically impossible to analyze that, let's say, manually, or it was very, very, laborious to do that. And we considered several approaches on how we can analyze the data from all these studies. And we realized that these three options can be very time consuming. So we explored a bit better whether the newer techniques of NLP can help us with that. So what is NLP? NLP is a branch of artificial intelligence, and you can do many, many things with NLP, but I will focus on topic modeling and text summarization. So what is topic modeling? So you give a text to the algorithm, to the software, and the software tries to detect either any patterns or any topics that emerge from the text, and can do that in several different documents, and then comes up with a probability of whether a topic is present in a specific area of the text. So just to give you an example, we fed the algorithm with all the data from this literature review, and then the algorithm came up with some word clouds like that. And these were the topics that the algorithm detected in the text that we fed the algorithm. And then this is up to the experts in the field to try to make sense of what these words might mean. And we gave all the word clouds to a group of experts, and we agreed that this is more likely referring to a motor dysfunction. So probably one of the criteria that we need to use for the diagnosis of DCM is that there must be a motor dysfunction. And there were a couple other models. Again, this has not been published yet, and we're still working on it. So these are not the final results, but I just want to give you an idea of how that process goes. And this is another word cloud that came up, and it contained very diverse terms like severity, progression, and we had trouble, understanding what this might mean. And again, because they were so diverse, all the words here, we couldn't come up with like a unifying theme that will kind of bring all this together. But then we realized that this might be some modifying, or as we call, reinforcing factors that in some questionable cases of myelopathy, they might make us lean towards the diagnosis of DCM. For example, if there is progression of the findings, if there is any instability, if there is any intramedullary signal, then it is more likely to be myelopathy versus not being myelopathy. And another technique that we used is the summarization. And this is actually, it can have multiple applications in medicine, I believe, especially now that the medical literature has been growing so fast, and it's very difficult to catch up with all the new publications that come up and all the new journals that come up, I would say, every day. So the text summarization provides like a concise summary, and it gives us the important features from the text. So we don't have to read the whole text ourselves, but just get the important points from the algorithm. And there are two ways to do that, actually three ways to do that. One is the extractive fashion, where the algorithm picks up some sentences or some words that consider very, very important, and considers that these sentences convey the important aspects of the text. And then there is the abstractive fashion, where the sentences did not necessarily pre-exist in the text, but it's a way that the algorithm can summarize the data and present the data to us. And then there are several ways to combine the two techniques. So let me show you how that looks. And so these are two summaries that came up with the abstractive summarization, and actually doesn't look very bad. And as you can see here, although this is an automated process, but there are some, we call them hyperparameters, some instructions that we give to the algorithm. And actually, you can modify these hyperparameters to a significant degree and get different results. And this is still kind of an art, meaning that there are no very specific rules on how you should modify or how you should, let's say, fine-tune these hyperparameters, and how you can get like a better summary of the text. But for example, here we had a more lenient length penalty, meaning that the algorithm was coming up with a longer text. Here we had a smaller length penalty, and the algorithm came up with a shorter text. And here's an example of the extractive summarization followed by abstractive summarization. And this is again a way that the technology can help us summarize the data from multiple publications. And although we're still at the early phases of this new technology, and they're still not performing optimally, but the way they are growing is really exponential. I mean, every few months we have a new model, we have a new significant progress in the field, and I believe that, and not only me, but many people believe that it will be very, very useful in the near future. And I always like to show that graph here, which is about growing a business, but also applies for anything that grows exponentially. So our minds are used in thinking about linear growth, and they're not so much used in thinking about exponential growth. So the new technologies initially, they grow exponentially, and there's always like a lag in the initial phases, and we explore them, we're not really impressed by them, and then we kind of dismiss them. But these technologies continue to grow, and there is like this point that they really then start to be much better than we're expecting, and they start to impress us. So with NLP, actually, I think we're at this point, if not beyond that point already. So let's go back to the myelopathy, how we treat it. So there were some guidelines published a few years ago, and this is the long version of the guidelines, and I won't really read them, but this is the short version that basically we do surgery, we offer surgery, and we consider conservative treatment only if the symptoms are very mild and they're not progressing, and if there are like significant comorbidities or the patient is of advanced age. And the reason is that myelopathy is a progressive disease, and also the outcome is related to the symptom duration. So if a patient comes to us and has symptoms for like 6 months, has a better chance of improving after surgery versus delaying the surgery and offering the surgery a few years down the road. And another thing that usually comes up is there any role for non-operative treatment? And this literature review, again from a few years ago, identified some shortcomings of the non-operative treatment for DCM. First of all, in the literature, they don't really define very well what is the non-operative care. And they include very different modalities like traction, bracing, and even when they describe these modalities, the details of the treatment are not very well defined. So other people define traction as several hours per day, others just a couple of times per week. And so it's unclear. So there is no some kind of standardization that allows to draw some kind of conclusions. And also in terms of the medication, there are many publications that report there was some kind of medication therapy, but this is not well defined. Also, they have done the non-operative treatment in patients regardless of their of the severity of the DCM. And we now know that for severe and moderate severity disease, then surgery is a better option. So there's several limitations from the literature, and there might be some actually research opportunities for the non-operative DCM treatment. And I think that there's been more focus of offering non-operative care in mild cases, and we need more clinical studies specifically for mild cases of DCM. Also, in regards to the post-operative care, this is not really standardized, and I think that there is room for developing standardized protocols for DCM patients after the surgery. And in regards to what might constitute a structured program, we think that strengthening of the neck muscles is very, very important, and probably isometric exercise work better because they can offer the muscles strengthening benefit without placing too much stress on the musculoskeletal system, or on the skeletal system actually. Then spine posture, we think, is also very, very important. Work ergonomics, targeted spine interventions can help with the pain that these patients might have and can facilitate a more effective physical therapy. And there is some early evidence that these patients should avoid excessive flexion or extension, but the moderate flexion should be safe. So probably if we kind of standardize these instructions or these type of treatments in mild cases, we might be able to find something interesting. In regards to the surgical options, there are several surgical options. We usually divide them in anterior, posterior, combined approaches, and also divide them in whether we're doing a fusion where we lock the bones together, whether we preserve the motion with an instrumented operation, whether we're doing all decompression or hybrid approaches. I'll show you a few examples. So in regards to selecting anterior versus posterior approach, there are many factors that come into play. Either is multi-level stenosis, we usually go from the back. If there is anterior compressive pathology, we usually go from the front. But remember that if we do a posterior decompression, the spinal cord kind of shifts back. So in this case, although there was this herniation compressing the spinal cord, and here we did the laminectomy, you see that the spinal kind of shifted more posteriorly, and although the disc is still there, but it doesn't have any kind of compressive effect to the spinal cord. In regards to anterior pathology, there are two main options. One is to do the fusion, where we are removing the disc, placing some kind of graft over there. Here is the allograft, and we place screws and plates to lock the bones together. And eventually, we want these two bones to fuse together and become a single bone. In this case over here, we remove the disc and we place an artificial disc. And although it sounds like a much better option, actually might be a much better option in many cases, there are some limitations of that technique. You cannot use it in every case. There are some contraindications. And also, we're lacking some kind of more long-term data about whether these devices are still functioning 20 years down the road. Well, with ACDF, it remains the gold standard. You do the fusion. If the bones fuse together, you don't have to worry ever again about that level of the spine. I would like to show you a video now, just to give you a visual of how an operation like that is being done. So this is a case of a 58-year-old lady with right arm, with arm weakness. You can see that she has a significant, let me go back. She has significant disc herniation at 5'6", and actually this disc herniation is very, very calcified. It's more like what we call osteophyte disc complex. You see it's more bone here. And here's the approach. Just to orient you, the head is to the left, the feet towards the right. The midline is over here. And over here, we're doing a dissection, and we're going to dissect between the carotid artery and between the esophagus and the trachea. So this is the plane that we have developed. And we're already on the spine over there, and we're developing the spine with this, we call them peanuts. And also we use scissors to cut through the prevertebral fascia. And here is the spine again. And here we use the cautery to expose the bone and to elevate the longus colli muscle. Just to give you a few anatomy, here's the longus colli muscle, and the anterior lateral aspect of it is the sympathetic chain. So we soon injure that area because then we can give the patient a Horner syndrome. The carotid artery is here, which we also need to be very careful about for obvious reasons. The esophagus a little bit more medially. And in the spine, a little bit more deep around here is the vertebral artery that we also need to be aware of its location. So many important structures in a very, very close to where we're working. Here we're placing the self-retaining retractors. Here's the spine after the cauterization. This is a pin that we put on the bone, and that will allow us to distract the disc space and open it up. And there are several advantages with opening up. It makes the discectomy easier and helps us correct any kyphotic deformity that might be present over there. So you see here, we place the knife to start the discectomy. You see the disc materials, like, you know, is this cartilage that we're going to remove, a little bit more soft material. And we use a combination of instruments to perform the discectomy. And here we use a high-speed drill bit to drill the posterior osteophytes. And over here, we're very close to the spinal cord. So that's why I use that instrument to confirm whether we have removed all the bone or whether we need to remove more bone. And there's still bone present there. So we're going to continue drilling to make sure we remove all the bone. And what is like 1 millimeter deep to us is the spinal cord. So this is where we're working. And this is the drill. This is where the tip of the drill is, and this is where the spinal cord is. And here's some different views of where the instrument is and how close the spinal cord is to where we're working. So that's why we go very, very closely. You see here, there's a bony fragment that we're trying to retrieve and remove it, but it doesn't want to come out. So at this point, we decide to work on the opposite side. And this here is the posterior longitudinal ligament. And you'll start seeing, as we remove that ligament, you start seeing this glossy white area. This is the dura. So this literally, you know, the spinal cord is right over there. So we need to be very, very careful not to apply any additional pressure to the spinal cord. And here, now we go about after this residual piece of bone. And finally, we're able to retrieve it. And here we're completing the decompression. We want to see the dura, we're very well decompressed. And here we use the sizer as a metallic instrument that will help us choose the right size of the graft. And here is the allograft. So basically is bone from a donor that is cut in a shape that will fit in that space. We're removing the pins. Here we'll put some bone wax on the bone to get hemostasis. And over here, we're working on the next level. And after we're done, I didn't show you the other level. It was basically the same thing. We're removing some osteophytes that will allow us to place the plate and to fit it a little bit better on the front surface of the spine. So here we're opening the holes for the screws. And here we're locking, they have a locking mechanism that we activate here. Basically rotate that to prevent the screws from kicking out. And these are the x-rays after the surgery. Again, this is, it was an ACDF, which is the most commonly done operation, one of the most commonly done operations for myelopathy. Another operation we frequently do is posterior. Another approach actually is the posterior approach, and there are two main options for that: is the laminoplasty versus the laminectomy and fusion. And you can see the difference here. Here is the vertebra before the surgery, and in the laminectomy we have removed the lamina, but because we have very important muscles attached to the spinous process, if we just do the laminectomy, then there's a very high risk for developing kyphosis after the surgery. So that's why we need to put the instrumentation, the rods and the screws to lock the bones together and to fuse them together. In the laminoplasty, we weaken the bone over here. You see there's a trough that we made here, and then we lift the bone up and place a plate to keep it up. And we give a much more space for the spinal cord, which is in this area, but we preserve all the important structures, all the important bony structures for the stability of the spine. So in that case, we don't need to fuse the spine. Again, it's a beautiful operation, but not every patient is a candidate for laminoplasty. There's specific contraindications, mainly if there is instability in the spine, if there is significant kyphosis or significant neck pain. And actually, we have developed like a modification to the technique, because what we realized is that when you only do the laminoplasty, because the spinal cord kind of sits posteriorly, there were some cases that the spinal cord was getting kinked by the edge of the bone over here. So we felt that it's very, very important when you do that operation to trim off the bone at C2 and C7, basically at the cranial and caudal end of the operation. And our experience with this modification is actually very, very good. I mean, even patients with significant pain did better after the surgery. There was significant reduction in the axial neck pain, but also significant neurological improvement in these patients. And again, this technique seems to be working very well in our patient population. And there's some hybrid constructs where we might choose to do both a laminoplasty and a fusion. This is something we've done a couple of times. We're still trying to figure out what is its role, in our armamentarium and in our list of surgical options. So this is still a field of active research. Now, I'd like to say a few things about the spine alignment. So we know that the spine should be aligned, meaning that the bones should be roughly one over the other, and there should be no significant kyphosis or coronal plane imbalance, because then the muscles of the spine need to work harder to maintain that alignment. So this is usually called cone of economy. And we have very well-established criteria for lumbar spine. Recently we started realize that the same criteria or similar criteria can be applied for the cervical spine. And here we see some of the most commonly used. I would like to just point out to the cervical sagittal vertical axis. So basically is distance between the C2 and the C7 if we draw a plumb line from C2. So the higher the distance is, means that the patient has more flexion of the overall of the spine, more kyphosis. So there is more work for the extensor muscle of the spine to keep the head up. So this is not optimal in patients with CSVA more than 4 centimeters. They usually have much higher pain and not as good quality of life. So one of the goals that we have with surgeries is to restore the normal lordosis and give as much improvement in the spinal alignment parameters. So I would like to show you another field of active research that we do. So this is how we position the patient during the surgery, prone position. And you see that there is a horizontal traction here. So we have applied the garden well tongs. You see here that these are tongs that they get attached to the skull. And through these tongs, we apply the horizontal traction. But during the surgery, we have the option of changing the vector of the traction towards the ceiling to induce more lordosis, or to elevate this support for the face, again, to give more lordosis to the cervical spine. So for example, here, I would like to show you two intraoperative x-rays. So this is how the spine looked by having only the horizontal vector of traction. And then when we change to both this oblique traction and also elevated the head, you see that we got a better alignment, better lordosis of the cervical spine. So we're actually actively trying to figure out which technique works the best. So we combine the elevation and the oblique traction. So we use one of the two. And so this is what we're actively looking. This is a pre-op and post-op. You see how we gave more lordosis to the spine. And here's the pre-op and post-op MRI. Another thing that we're actively looking at is what is the quality of life for patients who undergo long posterior fusions, because we know that 50% of the range of motion of spine comes from below the C2. The other 50% comes between the head and the C2. So in theory, losing 50% of the range of motion is associated with should be associated with significant reduction in the quality of life. But our impression is that this residual 50% is more than enough for the daily activities that we very rarely use 100% of the range of motion of neck. But again, this is something we are actively looking at with our patients to see if this is the case or just a false impression that we have. Now, in terms of surgical prognosis, there are several publications that they report that surgery can have a very good outcome, and they have established that at different time points. As you can see over here, the overall effect is definitely positive towards improvement, and this is for the JOA, so this is for the neurological outcome. This is for the overall neck disability, and you can see that is also significantly improved at multiple time points. And these previous publications were just describing, what is the overall outcome. So there have been some efforts in trying to quantifying or trying to prognosticate a little bit better. So this is a more recent publication where they're trying to provide an easy to implement prognostic scale about who will respond or who will not respond to surgery for DCM. And they then defined that the preoperative kyphosis, the number of levels that there is compression in the spinal cord from both the anterior and the posterior, and also the length of the spinal cord changes, they call them the intramedullary lesion. So they found that these three factors are very important for predicting what is the outcome from DCM surgery. But DCM surgery is not risk-free. There are several complications that can happen. Some of them they're rare, but some of them are serious, but hopefully, thankfully they're rare. For example, spinal cord injury to the carotid or the vertebral artery, injury to the esophagus. Some others, they're rare, but they're more easily managed, or they might be self-limiting. Like if there's injury to the recurrent laryngeal nerve from anterior approaches, because we're working very close to that nerve. Or as we discussed, there might be Horner syndrome if we injure the longus colli muscle. But most of these are, or some of them can be self-limited. For example, the recurrent laryngeal nerve injury most of the times is neuropraxia. So basically, it was just from the retraction of the nerve, and it gets better after a few weeks. Very rarely, it is due to a transection of the nerve that is associated with a permanent deficit. But what we deal with most commonly is if we do a fusion, that the bones might not heal together, might not fuse together. If we do a fusion, we might see additional disease at the areas above and below the areas that we fused. And another common, not common, but a complication that we see from time to time is the C5 palsy. It's basically is weakness to the deltoid and biceps muscle after surgery. So here's a publication that I tried to come up with a percentage of what is the cumulative incidence of these complications. But all these studies, they provide us with an overall view or some overall description of what the outcome will be or what the complications might be. But they are not very specific they're not individualized. So I would like to show you an area of active research that we do. And we're using the data from the National Surgical Quality Improvement Program of the American College of Surgeons. So this is probably the biggest database that we have for surgeries. And we have applied some newer type of analysis, basically machine learning algorithms. And they have several advantages over the more traditional, let's say, logistic regression or linear regression. First of all, their overall methodology, what you do in this case is you take 100%, all the data, 100% of them, and then you split them into train. So you split in 70% for training the algorithm, and then you keep the 30% of the data that the algorithm never sees. And you come up with a model, and then you check that model with the test data and see how well that model performs. So it's a very it's a clever way to do like an internal validation of the model. And also these algorithms, they're very good because they can detect non-linear relationships. So for logistic regression or linear regression, there's this assumption that an increase in one value leads to an increase in another value, the outcome, or an increase in one of the predicting features has a linear relationship with one of the outcome measures. But this is not always the case. And these algorithms, for example, the exit boost, cut boost, these newer machine learning algorithms can actually detect non-linear relationships. And overall, they provide higher prognostic and predictive accuracy than logistic regression. And they also allow for more accurate predictions at the individual level. So I'll show you here how one of our websites look for spinal tumors, but as I said, we're actively developing a very similar one for cervical spine surgeries. So you go here and you insert the age, the sex, all these parameters that they can have a predictive value. And then the algorithm can give you a specific prediction for that individual. So it can show you that there's an 8% chance for a prolonged length of stay versus 20% for a not prolonged length of stay. And that's specific for that patient, not just for the patient population in general. And also, it allows you to assess what is the overall feature importance, both at the individual level. So let me go back here. So this is at the individual level. So the algorithm shows us that these feature values are very, very important to predict the long length of stay for that specific patient. But the algorithm can give you also some estimations about what are the features that are important for the overall patient population. If you want to do some population-wide intervention, then this is a more helpful feature important scale. So for example, here it shows that age, this specific CPT code, and for example, if the American Society of Anesthesiology class is 2, so all these values probably they are associated with higher, they have a higher importance for the patient population. So I will stop here to allow time for questions. Thank you for your attention.